Great, you guys are back for part 3. We'll now cover how we manage a case of FIP treatment-wise.
So once we have a diagnosis, we have to think about prognosis and have a chat with our owners. Now, we are in a much better situation than we were 5 years ago. So 5 years ago, we didn't have directly acting antivirals that were effective, or at least we didn't have access to them. They were starting to be discussed around that time. And at that point, the prognosis was grave. We would see very rapid progression typically in our cats that had effusive disease, where they had these effusions in their abdomen, in their chest. A median survival from time of presentation was about 1 to 2 weeks. The progression with the non-effusive disease was much more variable. So we would see some cats with neurological signs progress within a matter of sometimes hours, days even, to succumbing of their disease. But with some of the other ones, particularly where they've just got enlarged lymph nodes or ocular changes, they could have had waxing and waning clinical signs over a number of weeks and sometimes months before ultimately it either peters out or sometimes they progressed on to having the classical signs of FIP. But these days, we are in a very, very different situation. We know that if we are able to administer directly acting antivirals to our cats at appropriate doses for how they're presenting, about 85 to 90% of cats will survive. Okay, so complete change around from what it was 5 years ago. Most of those cats respond very rapidly and completely to the appropriate doses of those meds, but we do have to acknowledge that a minority of these cats will have an incomplete or slow response, and some of those will relapse whilst on treatment, and a minority of cats will relapse following completion of what had originally appeared to be a successful treatment course. So we do have to kind of go through with owners that sometimes we're not able to achieve a cure in every case. So when we think about our prognosis and our treatment and our diagnosis, one other thing to think about is what your expected time is for the time frame from collecting those samples, particularly if we're thinking about submitting samples of abdominal fluid off to the lab, if we're thinking about submitting samples of tissue samples or aspirates for kind of immunohistochemistry, immunocytochemistry, or PCRs. If we think about it, some of those tests, even sometimes cytology, when we send it away to an external lab, we may be looking at a turnaround time of 5 to 7 days. And for the PCRs and immunocytochemistry, potentially even longer. And, it may also be complicated by the presence of holidays, bank holidays. The times of year can sometimes limit the accessibility to certain laboratory tests that we have, particularly with our send away times. And what we have to mesh this with is the fact that with these cats is that if we don't start treatment soon enough with some of them, we will have them succumb to disease before we have some of these diagnostic tests that ideally we would want to have a really kind of confident diagnosis in FIP if we're thinking about kind of making sure that we've ruled things in and ruled things out. If we're thinking about staining for the virus and finding that it's there, it being this happy place of confirming FIP. The reality is that we may well be in this stage here where we've got sample collection, where we're already fairly strongly suspicious that we've got a case of FIP. We've looked at the sample under the microscope and we've got evidence of pyogranulomatous inflammation. We don't find evidence of another disease process, but we may be pending the serological tests like, say, toxoplasmatitis and things like that, bacterial culture, and staining for the virus or PCRs for the virus. So we may not necessarily get down into this section before we're actually already in the stage of needing to think about treatment for our cases to stop them from succumbing to disease before we get to that stage. Now, there have been a number of antivirals trialled against FIP and basically in the management of FIP and the treatment of feline coronaviral infection. And these have been used both in vivo and in vitro. There's been a much smaller number of cases that have gone for in vivo studies than in vitro ones, as you might expect. Now, people have been predicting an RNA virus-based pandemic following a spillover event at a wildlife to human interface for a very long time. I can remember reading about it about 15, 20 years ago. And pharmaceutical companies have been eyeing up this as a potential source of revenue if only the worst were to happen. And then what ended up happening is they were originally thinking about SARS, and then SARS fizzled out, then MERS fizzled out too. And the hemorrhagic fever viruses, things like Ebola, they've mercifully been contained to a small number of countries, particularly sub-Saharan Africa areas, with those small number of outbreaks very closely together. People are starting to get twitchier and twitchier, and the wheels of R&D for these antiviral agents and vaccine platforms were slowly turning in the background. Now, the amazing work of Niels Pedersen and colleagues brought to us the nucleoside analogues GS441524, and then also, and the work was done for this a little bit earlier, a protease inhibitor, GC376, and you can see them written down on here. Shortly after these agents were reported on, we started to see black market versions of which being widely disseminated via various online platforms, because at that time legal versions did not exist. Now, the other non-specific agents that have been shown to have some efficacy, particularly in vitro, things like mefloquine, itraconazole, cyclosporin, they have been described, but again, their use in vivo are not necessarily. I know that people have been trying to look at the use of mefloquine in cats, and we've certainly had very limited use of using it, but we know that the direct-acting nucleoside analogues have been far more effective at it. So what do we have in terms of the direct-acting nucleoside analogues? So these are medications that competitively inhibit the activity of these naturally occurring nucleosides that we have in our cells, things like adenosine, cytosine, uridine, guanosine, thymidine, and inosine. So these are kind of chemicals that you probably remember going back to your biochemistry days at vet school. So these agents are required in the production of RNA and DNA, and we use a lot of nucleoside analogues in the human and the veterinary fields. Now, when it comes down to the management of RNA viruses, we are able to get some very specific RNA inhibiting nucleosides that have a lovely, nice, safe margin. Now, they are legally available in the UK from companies such as Bova and Summit, so they're not directly available through other means. Owners can't get them on a written prescription, they can't get them from human pharmacies, and realistically accessing these medications, be it in tablet form or injectable form, which is necessary in some of them, medication alone without any markups or minimal markups, without any investigation and monitoring, and without the dose adjustments for weight gain and relapse, we are easily looking at somewhere between £2,000 and £10,000 for your average size of cat. If we're thinking about some of our larger cats, such as the Savannahs, the Maine Coons, then we can easily exceed those levels. So with the nucleoside analogues, the ones that we know the most about is GS441524. This mimics adenosine. It inhibits the replication of various different viruses, including SARS, Hep C, dengue, influenza, and West Nile. And the most data, as I said, is available for this medication. Its prodrug is remdesivir, and this was this is something that came onto the market from a human medication point of view during the pandemic. It inhibits also MERS, Ebola, Lassa, Junin, and the respiratory syncytial virus as well. And the nice thing about both GS441524 and remdesivir is that they've got low cytotoxicity across a wide range of cell lines as well. And with GS441524, it's available in oral form, whereas with remdesivir, it's a legal formulation for parenteral administration. And typically we use that in cats that are unable to swallow or have ileus, where we're worried that their absorption of the oral forms of the medication aren't going to be great. Now, resistance to these antivirals has been noted following their use, so there is concern if they're used inappropriately. There are other analogues out there. So we have the cytosine analogues, such as molnupiravir and EIDD1931. EIDD1931 is legally available in the UK from Bova, and molnupiravir is available elsewhere in the world. There's much more limited data available as compared to the adenosine analogues, but we do know that it can be effective, including in cats where remdesivir and GS have failed. But we feel that actually it's associated with a longer time to having a clinical response and a perceived increased risk of side effects such as neutropenia. They also work in very slightly different ways. So whereas with the adenosine analogues, they inhibit the viral replication, with the cytosine analogues, they seem to result in a replication burst and then a collapse of the viral replication because it induces a large amount of replication errors being kind of incorporated into the various viruses. In terms of our drug dosages and frequency and duration, this keeps on changing. So this is where you do need to keep up to speed all the time with them, and it's worth reaching out when you do have a case as to what is the current recommendations, because they can change very, very quickly every 6 to 12 months or so, for example. So the formulation and route that you want to be doing really depends on the owner, the cat, the finances, to a degree. Unfortunately, we're not necessarily able to say for an owner that isn't able to afford very much, it's okay, we'll go for the cheaper option. Sometimes we do have to go for the more expensive options where the cat is quite sick. So we typically reach for oral GS for most of our cases where we can do, and we can use this from the start. It was non-inferior to using remdesivir, which was the first drug we had access to. Oral GS is cheaper than remdesivir as well. So again, if we're able to reach for either the tablet or liquid versions of that agent, it's going to be more budget friendly than reaching for injectable remdesivir. But as I said, we need to use remdesivir in our sicker cats. The dose that we use depends on how the disease is manifesting. So we do really need to carefully look for presence of neurological or ophthalmological involvement, because where we are seeing either neurosigns or ocular signs, we do need to go up on our doses. And if in doubt, we do dose up as well. And when we're looking at our tablets, we round up the doses to the nearest quarter tablet. We also need to make sure that we're adjusting upwards for weight gain, particularly in our kittens, and even with some of our adult cats, they'll often regain condition, and if that's unbeknownst to us and we don't dose adjust, we can sometimes end up underdosing these cats during treatment. Now, if they're very effused and they end up, which is what we expect them to do, is reabsorbing a lot of that fluid from the abdomen, we don't back off on the dose in those cats, even though they might have lost a bit of weight as that fluid is resorbed. We just keep an eye on their weight until they start regaining their condition and potentially start going up above their original starting weight. Most of the courses we are kind of aiming initially for about 12 weeks as a minimum. This was based on a lot of the earlier studies. There is limited evidence for shorter courses, but anecdotally we are aware that more people are reaching for shorter courses, likely as a consequence of financial limitations. We know that it's more likely to be effective in the cats that have effusive disease. Potentially that's just as a consequence of our knowledge base on there, and that some of the studies that have done have primarily looked at cats with effusive disease. We also, in the shorter courses, want to be really demonstrating that they have responded very rapidly and that we've got a pretty normal cat with normalised alpha-1 acid glycoprotein before we even think about stopping the medication. And this is where keeping an eye on their clinical signs, keeping an eye on what their alpha-1 acid glycoprotein is doing is helpful, because it means that we can identify cats that are at risk of relapsing or that aren't responding completely, and then consequently upping their doses of medication to try and stop them from being one of the ones that's going to relapse with their disease. These cats also need supportive care. It's not just antivirals alone, although they are the mainstay of treatment. Some cats we do need to drain the fluid if it's around the lungs. We don't typically, thankfully, need to drain the pericardial fluid where it's present, unless it's causing tamponade, which it very, very rarely does. In the abdomen, again, we very rarely need to drain the fluid from the abdomen. So again, not dipping in and out of that is also usually a good idea. Worth being aware that some of those cases will go on to develop septic abdominal effusions. We're not entirely sure whether that's as a consequence of us sampling it or whether it's translocation in what are otherwise immunologically crippled cats. And again, similarly, when we go into the chest to do chest drainage, there is always the risk that they may have iatrogenic pyothorax, and that may be a complication. So again, we want to keep an eye out for that. We want to manage them for dehydration. These are often sick cats, so we want to rehydrate them, particularly sort out their potassium levels as well, and keep them on fluids until we're happy that they're eating. And we might need to give them appetite stimulants. We might need to give them medication to address any ileus that's present. We might need to pop in feeding tubes as well. Some cases will need immunosuppressants or immunomodulatory agents. We try and avoid using immunosuppressants where we can do, but if we've got life-limiting immune-mediated diseases like an IMHA, we might need to. And then we also might need to use topical treatments as well for the management of uveitis. Some clinicians have considered using immunomodulants such as polyprenol immunostimulant, but there's minimum evidence base for that use in combination with antivirals at this time. It may be possible that we do get more evidence base as we move forward, but as we said before, we know that the overwhelming majority of cats will have a good clinical response if we treat them with the antivirals. When we've started treatment, we do need to monitor these cats on that treatment. As we said previously, we do need to adjust the dose for weight gain. And what we can consider to be kind of the minimal response is, as well as keeping up to date with the owners and how they're doing, is have a physical examination, including weight and abdominal girth for our effusive cats every 2 weeks, at 2 weeks, at 6 weeks, and at 12 weeks. So the idea of that is we want to be making sure that within those first few weeks they are responding to treatment and we're starting to see kind of resolution of the effusions that are present. We then at 6 weeks we want to see them being pretty normal where we can do, and then 12 weeks is before we stop the medication and signing them off. Where we've got financial availability and we are going to be prioritising our medications over some of our following up monitoring is point of care imaging. So we want to be confirming the resolution of that effusions, and we want to be kind of documenting where possible improvement or resolution of the changes to the organ systems that were previously affected. We do sometimes see persistence of lymphadenopathy, but we're not wanting to see progression of that, and ideally we want to see some improvement in it. We want to be thinking about doing blood analysis, ideally to confirm resolution of any other changes, particularly inflammatory ones, by heme, chem, and in particular measuring alpha-1 acid-glycoprotein where we've got access to that. And then with our tricksy cases, so the ones that aren't really achieving resolution like we're wanting to, the other thing we can consider doing is therapeutic drug monitoring, where we are collecting samples at different time points during the day and seeing where our drug levels are. It appears that some cats are able to clear the medication a lot faster than others, and others aren't necessarily able to absorb it as well as others. So again, sometimes they need to have their doses increased, sometimes they need to have the dose frequency increased as well. And this monitoring, we also want to look for evidence of relapse and any adverse effects too. In terms of what we were expecting from these cases, the expected response is we are, first of all, we want to be looking, there could be disease progression, there could be complications, and we want to be thinking, if there is evidence of progression, is that a complication of what's going on there? Is the disease just getting a bit worse? And we can see the effusions getting a bit worse within the first few days. We may see evidence of progression to having ocular signs or neurological signs when previously there weren't. And we might need to think about increasing our dose of medication. Well, kind of if we do see neurological signs appear, we need to be given the medication that's dose appropriate for that particular complication. If we've already the dose treatment for that and we're seeing new things appear, we might need to escalate it further from there. We also might be needing to think about how some of these cats might go on to develop evidence of septic effusions being present. We've also seen some cases where we might see evidence of cardiac dysfunction, myocarditis, and consequently effusions developing as a result of congestive heart failure, where we might not necessarily be seeing the protein levels that we would typically expect for FIP, but these cats may be hypotensive, maybe be feeling quite kind of grim as a consequence of cardiac issues alongside the FIP that's causing it. We are expecting to see a significant improvement. So actually a lot of these cats are looking hugely better clinically within a few days in themselves. They're often a lot brighter, a lot happier, and that pyrexia resolves. We'll then start to see the effusions resolving, and then kind of after that we might start seeing the granulomas improving. And as we said previously, sometimes the weight may transiently decrease as those effusions resolve, and then as they improve their body condition, as they gain weight, particularly if they're growing kittens, their weight may go up, and it can go up really quite rapidly. So giving the owners permission and even recommending to them to get some like baby weighing scales so they can weigh them kind of every week or so, and then letting them know what the thresholds are for that particular dose of medication, at which point you are going to be recommending a dose increase, can be very helpful, such that if that weight increase occurs before they were next due to see you, they know to reach out to you to confirm that medication increases are necessary. In terms of blood work changes, we were expecting the icterus to resolve within the first couple of weeks. The hypoglobulinemia and anemia can take a bit longer. Usually it's within 6 weeks, but sometimes it's longer. And because of the reabsorption of the fluid, we sometimes see that hypoglobulinemia go up within the first couple of weeks. Alpha-1 acylglycoprotein should be kind of normalised within 6 weeks. We should be really seeing it improve within the first couple of weeks as well. And if we are, seeing a significant improvement in our alpha-1 acylglycoprotein in response to supportive care and use of antivirals, that is a very, very strong indicator that we are dealing with FIP. With our diagnostic imaging, those effusions are going to be nearly resolved within a couple of weeks. So if they're still there after those 2 weeks, we will be wanting to look for either complications being present or an inadequate dose being given, or there being something else going on that we might need to address. The lymph node changes, particularly in the abdomen, it can take a lot longer, and sometimes those changes may persist, and that can be very worrisome when we hit the 12-week time. If we've got a clinically normal cat, about where we go from there. Sometimes we do just need to stop the medication if everything else, including alpha-1 acylglycoprotein, has been resolutely normal, and see what happens. As we said, these medications are generally very, very well tolerated, with the most major side effect being on from a cost side of things. But side effects have been described where we give remdesivir, particularly if we're giving it as a sub-Q injection, we can get injection site reactions. It's very, very acidic, so we can get some quite nasty changes happening there. When we give it intravenously, we may also see hypotension or bradycardias. We can reduce the risk of that by giving it as a very slow intravenous infusion and just being aware of it. It is possible, and you'll see it described, that where people have used remdesivir and GS 441524, we can see urolith formation. It's rare, and as far as we're aware at the moment, it's associated with use of very high doses of medication, usually with the kind of black market versions of it, where the levels of medication within those products were often much higher than they said on the packet, which it might sound a bit counterintuitive, having more drug in there than you'd expect, but actually it was part of a marketing thing, and they were able to say, those cats were having a better response, or more cats responded to those medications, and it's probably because they were just having higher doses of the antivirals. And so we have seen some cats that were getting kind of multiple daily doses at very high level because they had neurological disease, developed stones, which ultimately caused urinary tract obstruction. So we know that it can happen. But I'm not really aware of it happening alongside the currently commercially available products out there where we know what we're giving. But if we are going up much higher on the doses for various reasons, maybe the therapeutic drug monitoring suggests they need the higher doses and they've got neurological disease, it is something that we do just need to be aware of. With remdesivir and GS, we can see transient hepatopathy. So this can be where we see the ALT being increased for an unexplained reason. We manage those by keeping an eye on them, sometimes using liver support medication. It does seem to be transient, such that when we stop the medication, it seems to return to normal. As to kind of whether we do stop the drugs sooner rather than later, again, we tend to kind of weigh up the risks of them having a relapse of their FIP versus what appears to be a minimal risk of their ALT being increased for a short period of time. Other things that we have seen or have been kind of queried or reported, and certainly seen in people on remdesivir, is a transient nephropathy. Again, not something we really appreciate in our cats. For molnupiravir and EIDD 1931, we can sometimes see nausea when they're administered. We can sometimes see neutropenia as well. So again, this is one of the reasons why we tend to be less keen on reaching for the molnupiravir and EIDD over remdesivir and GS 441524.
So that's how we would do it in the perfect world, but we know that these days that perfect world isn't there, and we have to be more pragmatic about it. In part 4, we're going to cover what we would need to think about if we were managing a case on a budget.